So how a patient of pituitary amenorrhea is, or amenorrhea due to pituitary gland due to failure of pituitary gland to produce FSH and LH, how a patient of this category will be described in the Plab 1. Remember that there are three causes of pituitary failure. One of them is Sheehan syndrome, one is pituitary apoplexy, and the third one is non-functioning pituitary adenoma. So can someone of you tell me what will be the sign and symptoms of non-functioning pituitary adenoma? What sign and symptoms can be produced by the non-functioning pituitary adenoma? Pituitary adenoma is a benign tumor. So what sign and symptoms can be produced by a tumor? Who will tell me?
It will cause compression.
Compression of which structure? Which structure lie in close proximity to the pituitary gland? An important structure.
The optic chiasma.
Yes, optic chiasma. So compression of the optic chiasma. What will happen if there is compression of the optic chiasma?
Hemianopia.
Homonymous hemianopia or heteronymous hemianopia? Which one?
Homonymous hemianopia.
Because the optic chiasma contain a nasal fiber from both the sides, so it will cause heteronymous hemianopia. So whenever there is a problem with the optic chiasma, heteronymous hemianopia is produced, while the problems due to any other structure that is affected, such as optic radiation or optic tract, it will produce homonymous hemianopia. Only in case of optic chiasma, heteronymous hemianopia will be caused. So don't forget this point. So a non-functioning pituitary adenoma, female who present to you with amenorrhea, and then there is a sign and symptoms of pituitary adenoma such as heteronymous hemianopia, and in signs of increased intracranial pressure such as headache and dizziness, then you can say that the cause of this amenorrhea is hypopituitarism. So this is one way by which a question of hypopituitarism can be described. Hypopituitarism due to pituitary adenoma, non-functioning pituitary adenoma, can lead to decreased production of the pituitary hormones. That can be follicle stimulating hormone, luteinizing hormone, or even it can be prolactin. Any pituitary hormone will not be produced. So signs and symptoms of hypopituitarism will be present in this form. Now, what is Sheehan syndrome? Sheehan syndrome basically occurs in postpartum period. What happens in postpartum period? Normally during pregnancy, the vascularity of the pituitary gland is increased. But during delivery of the baby, if a woman lost a massive amount of blood or there is a massive hemorrhage during delivery, what will happen? The blood flow to the pituitary gland will be reduced, and ischemia of the pituitary gland will lead to necrosis or death of the pituitary cells. So whenever there is a death of the pituitary cells, no hormones will be produced by the pituitary gland, such as FSH or LH. So hypopituitarism can occur due to Sheehan syndrome. Ischemia of the pituitary gland due to massive hemorrhage during delivery of the baby is called Sheehan syndrome. So amenorrhea in the postpartum period the cause will be hypopituitarism. And in the question, history of massive hemorrhage or postpartum hemorrhage will be mentioned. Now, hypopituitarism can also occur due to pituitary apoplexy. Pituitary Sheehan syndrome. In Sheehan syndrome, the blood flow to the pituitary gland was decreased. But in pituitary apoplexy, what happens that a pituitary tumor or a pituitary adenoma outgrows its blood supply, or you can say that there is a spontaneous hemorrhage into the pituitary adenoma. So pituitary apoplexy is the pituitary adenoma outgrows its blood supply, due to which ischemia can occur, or spontaneous hemorrhage into the pituitary gland is called pituitary apoplexy. So non-functioning pituitary adenoma, Sheehan syndrome, and pituitary apoplexy, these three things can lead to hypopituitarism, and the person can develop amenorrhea due to decreased production of FSH and LH. So this is how you can differentiate between hypothalamic and pituitary amenorrhea on the basis of history, because in lab investigation, both of them will have low LH and FSH levels and low estradiol. So you cannot differentiate between them on the basis of lab investigation or lab findings. You can only differentiate it between them through the history. Now we are done with the causes due to hypothalamus pituitary gland that can lead to amenorrhea and how to diagnose them correctly. Now the third endocrinal cause is due to hyper or hypothyroidism. So if a female with amenorrhea and features of hypothyroidism or feature of hyperthyroidism, then you can say that the cause of amenorrhea is in the thyroid gland. So it's easy to diagnose a amenorrhea due to thyroid gland problems. Now, another cause was prolactinoma. In prolactinoma, you all know that prolactin level will be very high, above 1000 in microadenoma and above up to 5000 in macroadenomas. So very high prolactin level and amenorrhea will make a diagnosis of prolactinoma. So now we will discuss the causes that are related to the ovary. First of them is polycystic ovarian syndrome. So polycystic ovarian syndrome, the basic chemical abnormality due to a genetic defect in the polycystic ovarian syndrome is increased LH. LH is increased more than FSH, and their ratio is doubled. LH FSH ratio is double. For the LH or FSH ratio is 2:1. This increase in the LH causes an increase in the androgen production. So whenever there is high androgen in the body, in the females, what will happen? Acne, hirsutism, amenorrhea, oligomenorrhea, infertility, subfertility, and obesity as well. There is one other chemical abnormality that is present in the polycystic ovarian syndrome, the genetic defect that leads to excessive production of LH also lead to insulin resistance. So because there is insulin resistance, so insulin level will be high, and high insulin level causes acanthosis nigricans. What is acanthosis nigricans? It is a sign of high insulin level, because high insulin stimulate the production or melanocytes, production of melanin by the melanocytes, which will lead to brown or black skin hyperpigmentation on skin folds such as axilla, groin, or neck region. So basically, you need to remember two things: high androgen and high insulin in polycystic ovarian syndrome. High insulin lead to acanthosis nigricans, and high androgen leads to acne, hirsutism, amenorrhea, oligomenorrhea, infertility, subfertility, and obesity as well. The investigation for polycystic ovarian syndrome, LH and FSH ratio will be double, and ultrasound, a pelvic ultrasound will show multiple cysts in the ovaries. So if a female has multiple cysts in the ovaries, but her LH and FSH levels are normal, then you will not say that it is a polycystic ovarian syndrome. You will just simply mention that there are multiple cysts in the ovaries. The criteria for the diagnosis of polycystic ovarian syndrome is double LH FSH ratio and multiple cysts in the ovaries. Also, there will be high insulin resistance on oral glucose tolerance test or fasting blood sugar. Fasting blood sugar will be high, and oral glucose tolerance test will also show the high blood sugar levels. So what is the treatment of polycystic ovarian syndrome? Generally, reducing weight or weight loss can improve. So there are two problems in the polycystic ovarian syndrome. One is menstrual irregularities and the other one is infertility or subfertility. So losing weight or reducing weight can improve the fertility as well as it can improve the menstrual irregularities. So the initial management that you will advise the patient is weight loss. And after weight loss, the medication that you can use for menstrual irregularities, they include COCPs and IUS as well. And for infertility, clomiphene citrate is the first line, plus metformin can also be tried. Clomiphene citrate basically induce ovulation, so it can be used as a treatment option for infertility in patient with polycystic ovarian syndrome, COCP for menstrual irregularities, and clomiphene citrate for infertility. And the initial management in both cases is weight loss. Metformin can also be tried, and even if all these drugs, the patient's symptoms does not improve, then laparoscopic ovarian drilling can be done. It is the last option that can be tried. So if they ask you what is the most important initial step in the management of infertility in a patient with polycystic ovarian syndrome, your answer will be weight loss. After weight loss, medicine can be tried. An important differential diagnosis of polycystic ovarian syndrome is congenital adrenal hyperplasia, because in congenital adrenal hyperplasia, there are high androgens. So high androgen signs such as acne, hirsutism, amenorrhea, oligomenorrhea, and infertility, they will be present in patient with congenital adrenal hyperplasia. So this was all about the polycystic ovarian syndrome. Is it clear, everyone? If there is any question, you can ask. So the second problem in the ovaries that can cause amenorrhea is premature ovarian failure. So whenever you hear the word ovarian failure, it means ovary fails to produce estrogen. So what will happen if ovaries fail to produce estrogen? The patient will have signs and symptoms of menopause, such as amenorrhea, infertility, hot flushes, night sweats, decreased sex drive, irritability, vaginal dryness, dyspareunia. So in premature ovarian failure, first of all, let's discuss the cause of premature ovarian failure. The cause of premature ovarian failure in most cases is genetic, but it can also be caused by radiation therapy or chemotherapy. So in a Plab 1 exam, a female who got amenorrhea after radiation or chemotherapy and her age is less than 40, then you will suspect premature ovarian failure. And the sign and symptoms and the presentation will be the sign and symptoms of menopause, such as amenorrhea, oligomenorrhea, infertility, hot flashes, night sweats. And because the problem is in the ovary, and I told you that whenever there is a problem in the ovary, FSH and LH level will be high. So in investigation, two raised FSH samples 4 weeks apart is a diagnostic of premature ovarian failure. What will be mentioned in the history? A woman with a history of a 39 years old woman or a 38 years old woman. Remember that this age limit is important. Amenorrhea before the age of 40 is premature ovarian failure. Amenorrhea before the age of 40 in a woman with a history of chemotherapy or radiation therapy is premature ovarian failure. Investigation will show two raised FSH levels of more than 25 or more on two occasions with the samples taken 4 weeks apart will make a diagnosis of premature ovarian failure. Also, estradiol level will be or estrogen level will be low because of ovarian failure, and the management is hormone replacement therapy until the age of 51, which is a normal age of menopause. The average age of menopause normally is 51. So if the patient develops premature ovarian failure, then the treatment is hormone replacement therapy until the age of 51. So premature menopause and premature ovarian failure. If a patient with premature ovarian failure does not get periods for 12 months, or if she has a 12 months amenorrhea, then we will call it as premature menopause. But if she is still getting some periods or decreased periods or oligomenorrhea or irregular periods, then we will call it as premature ovarian failure. So no periods for 12 months before the age of 40, it is premature menopause. No periods after the age of 40, but before the age of 45 is early menopause. And no periods after the age of 45 is menopause. So there's a slight difference between these terms. In premature ovarian failure, if the patient is still getting periods, but they are irregular, we'll call it as premature ovarian failure. And it can also cause premature menopause, which is if the patient does not get a period for 12 months before the age of 40. No periods for 12 months after the age of 40 is early menopause, and after the age of 45 it's menopause. What is perimenopause? Perimenopause is menstrual irregularities plus vasomotor symptoms, but not yet 12 months amenorrhea. So this was all about the ovarian causes of amenorrhea or oligomenorrhea in females, which were polycystic ovarian syndrome and premature ovarian failure. The clinchers for both of them is that in PCOS and obese females with signs of hyperinsulinism and hyperandrogenism. Hyperinsulinism is acanthosis nigricans, and hyperandrogenism is acne, hirsutism, and menstrual irregularities and infertility. In an obese female is PCOS. Clinchers in lab investigation is LH and FSH ratio is doubled, and ultrasound will show multiple cysts in the ovaries. While for premature ovarian failure, a female with a history of chemotherapy or radiation therapy and amenorrhea before the age of 40, the diagnosis is most likely premature ovarian failure. The hints in the lab investigation is raised FSH more than 25 on two occasions will make the diagnosis of premature ovarian failure. The treatment for premature ovarian failure is hormone replacement therapy till the age of 51. Now, how to approach a female with infertility? The next topic is investigation to assess infertility in females. So, is it clear, everyone, up to this point? No questions? So, let me ask you questions. So, Dr. Shafraz, can you tell us what will be mentioned in the history of a patient with hypothalamic amenorrhea? What are the important diagnostic points in the history for hypothalamic amenorrhea?
Sure, just a minute. So you asked about features of hypothalamic amenorrhea?
Yes. What are the important diagnostic point in history to make a diagnosis of hypothalamic amenorrhea?
There would be amenorrhea when checked. There would be low FSH and LH.
So low FSH and LH, they are investigated hints in the or diagnostic point in the investigation or lab values. What will be mentioned in the history? Because in pituitary, hypopituitarism, amenorrhea, FSH and LH and estradiol level will be low. So what are the specific points in favor of hypothalamic amenorrhea? Someone else would like to answer?
That will be a person would either be an athlete or maybe doing some excessive exercise. So
Yes.
that amenorrhea, and the lab investigation would be low FSH and LH and estradiol.
Yes. In the history, it will be mentioned that an athlete or a sportswoman with amenorrhea or a woman with a history of bulimia nervosa with amenorrhea. So these are important clinchers to make a diagnosis of hypothalamic amenorrhea. That is a sportswoman or a woman with a history of bulimia nervosa or a marathon runner female who developed amenorrhea. So these are some specific points in history that will favor the diagnosis of hypothalamic amenorrhea. So, how to investigate a patient or a female with infertility? The first thing that we need to evaluate in a female who present to us with infertility is to assess ovulation. The first thing that we need to do is that to assess ovulation to see that if the ovulation is occurring or not. And to assess ovulation, the test that we need to do is mid-luteal progesterone level. Mid-luteal progesterone level are assessed to see if the ovulation is occurring or not. Remember that after ovulation, the follicles are converted into corpus luteum, which secrete progesterone. So measuring the mid-luteal progesterone levels can tell us about the ovulation. And what is the time period or the day on which you need to measure the mid-luteal progesterone level? Remember that mid-luteal progesterone level means 7 days prior to the next period. So if the patient is having a 28-day cycle, then 21st day would be the day to measure the progesterone level because it will give accurate results. But if someone has a cycle of 32 days, then at which day you need to calculate the progesterone level? That will be the number of days of the cycle minus 7. So the number of days of the cycle is 32. 32 minus 7 is 25. Similarly, in a patient with a 24-day cycle, we'll measure the progesterone level at 17th day. So number of days of the whole cycle minus 7 is the day to calculate the progesterone level to assess the ovulation. So the first thing that we need to do in a patient with infertility is to measure the progesterone level that is measured 7 days prior to the next period. So if the progesterone levels are more than 30 nanomole per liter, then we can say that it's perfectly normal and there is ovulation, and no further biochemical assessment is required in this regard. But if the progesterone level are less than 30 nanomole per liter, then we'll say that there's problem with the ovulation and we'll refer the patient to a gynecologist for further assessment. Now, the second test that we need to do in a patient with infertility after progesterone level is FSH and LH level. Now, what will FSH and LH level tells us? If FSH and LH are low, it means problem is in the pituitary or in hypothalamus. If FSH and LH level are high, then we can say that if LH and FSH ratio is double, then we'll say that it's polycystic ovarian syndrome that is causing the infertility. And if FSH levels are high, more than 25 on 2 occasions, then we'll say that it's premature ovarian failure. So progesterone level and FSH and LH level, they both can help us to diagnose the cause of infertility in females. Now, what if progesterone levels are normal, FSH and LH levels are normal? Then the third investigation that we can do is hysterosalpingogram. What is hysterosalpingogram? Hysterosalpingogram is basically an X-ray that is taken after injecting a dye into the uterus through a cannula to check the tubal patency, to see that if the fallopian tubes are not blocked or they are patent or not. So these are the investigation that we can do in a patient who present, in a female who present to us with infertility. First one is progesterone level, mid-luteal progesterone level. Second is FSH and LH, and third is to see the structural abnormality of the uterus and the fallopian tube, that is hysterosalpingogram. Now, One more cause of amenorrhea, that is post-pill amenorrhea. If someone has taken COCPs,
Sorry, one question
what?
about level of progesterone. Should it be more than 30 millimole per liters, or that is the normal value, the progesterone level?
Yes,
Sorry, I didn't get that.
normally progesterone level should be high, more than 30 nanomole per liter. The
Right.
mid-luteal progesterone level should normally be more than 30 nanomole per liter. If they are 30 nanomole per liter, then it means it's a normal process and ovulation is occurring. But if they are less than 30 nanomole per liter, then we can think that there is a problem with ovulation and we need to assess the patient further.
Okay, that's fine. Thank you.
Any more questions? So post-pill amenorrhea. So far we have discussed the causes of amenorrhea. Hypothalamus, pituitary can cause amenorrhea, and thyroid problems can cause amenorrhea. Polycystic ovarian syndrome can cause amenorrhea, and premature ovarian failure can cause amenorrhea. And then there is another cause of amenorrhea, that is post-pill amenorrhea. Sometimes the periods may take some time to return back to normal after stopping or after stop taking combined oral contraceptive pills, because COCPs, they suppress the SH and FSH and LH production from the pituitary, so they can cause amenorrhea. So if a female present to you with amenorrhea after stopping COCPs, then it's perfectly normal. You will reassure the patient. If the amenorrhea is less than 6 months, because it take almost 6 months the periods to get normal after stopping a pill. It's a normal phenomena. But if the amenorrhea persists more than 6 months, then you will investigate the cause of amenorrhea. You will order the FSH and LH levels in post-pill amenorrhea, because the pill or the COCP suppresses the FSH and LH production. So LH and FSH production will be LH and FSH levels will be low in post-pill amenorrhea, because they have suppressed the release of FSH and ALH. So it's a normal phenomena. But if the amenorrhea persists more than 6 months, then you will order LH and FSH level, and depending upon the result, you can decide whether it is a premature ovarian failure, because premature ovarian failure FSH level will be high, more than 25 on 2 occasions. So how to manage post-pill amenorrhea? Reassurance if the amenorrhea is less than 6 months, and if amenorrhea is more than 6 months, then order FSH and LH level to investigate the cause of amenorrhea. Again, important note, although the most common cause of premature ovarian failure is idiopathic or genetic, it can occur after chemotherapy or radiation therapy. So if chemotherapy or radiation therapy history is mentioned in the scenario, then you will suspect premature ovarian failure. So this was all about secondary amenorrhea, its causes, and how to differentiate the different causes of amenorrhea. Does someone have any question? Okay, if you people are not asking question, then I'll ask the question.